Hi, my name is Tejas Venkataram. I'm a neurosurgeon, and this is my friend Bon Jovi. We are here with Answer today to answer your questions about neurosurgery. Let's start. What's the difference between moving your arm and thinking about moving your arm? How does your body differentiate the two? So we move our arm based on the primary motor cortex, which is the part of the brain responsible for the actual movements of the arm. However, in front of the primary motor cortex is the supplementary motor area and the prefrontal cortex. These two areas of the brain are very important in planning a particular action. So before I actually move my arm, the premotor cortex and the supplementary motor area plan this action, send the signals to the motor cortex, the primary motor cortex, which then carries out the action of moving my arm. So it's this complex sequence of feedbacks which causes the actual movement. So when you're thinking about moving your arm, it's the primary motor cortex and the supplementary motor area which are firing. And when you actually move your arm, it's the signals from those two areas which has gone to the primary motor cortex which has resulted in the action. This connection between those two areas in the primary motor cortex is a matter of fractions of milliseconds. It is that quick, it's so quick we don't even realize that we're doing it. If I have a brain tumor in my frontal lobe, will it affect my personality? Yes, it may. And not just tumors, it can be trauma as well, or any other problems with the frontal lobe. You see, the frontal lobe is the one lobe that separates us from the so-called lower animals. It helps us with our personality and executive decision making. So damage to the frontal lobe can cause problems with personality, with the signature being disinhibition, where a patient will find it difficult to interact in social situations. Apart from that, they can also have dysexecutive syndrome, which affects a patient's ability to perform complex sequential tasks, such as driving a car, where you need to first press the clutch, change the gear, release the clutch while you're pressing the accelerator. This complex series of tasks will be difficult with those who have problems with the frontal lobe. Similarly, the parietal lobe has its own functions, which when damaged can cause something really interesting known as right-left agnosia, which the patient feels confused as to which is the right side and which is the left. Also something known as hemi-neglect, where the patient's entire left or right side of their environment is completely neglected from his consciousness. So a patient with hemi-neglect may shave one side of his face, but completely ignore the other side. So every part of the brain has their own functions, and depending on what is damaged, those symptoms will manifest. Treating these weird syndromes, interesting syndromes, will usually depend on what the actual pathology is, whether it's trauma, whether it's a tumor, whether it's a vascular malformation. The treatment of those depend on what the actual pathology is. Why are left-handed people often excluded from psychological and neurological research studies? There are probably a couple of reasons as to why this happens. Firstly, the number of left-handed people in the population is extremely low. It's at around 10%. So coming up with a sample size large enough to have good studies with purely left-handed people is quite logistically difficult. Another myth is that left-handed people are right brain dominant most of the time, but that is actually not true. Left-handed people 70% of the time are left brain dominant as well, similar to most right-handed people. So unless the study is about a lateralization of the brain, where you're trying to decide which side of the brain controls what, it actually may not matter too much whether it's a right-handed or a left-handed person. What is awake brain surgery and how does it work? Awake brain surgery is probably the most headline-grabbing surgery in medicine. It involves the patient being awake while we dig into the brain, which is mind-blowing, no pun intended. So what we do is, the anesthetists are good friends. They keep the patient sedated while we take an incision over the scalp. This, though, has pain receptors. The anesthesia numbs down the pain. Then we open the skull by a craniotomy and then open the covering over the brain. This is when the anesthetists reverse the effect of the anesthesia so that the patient is a little more awake. So the basic concept of an awake brain surgery is that the brain doesn't have pain receptors. The brain doesn't feel pain. So once you've gotten access to the brain, the rest of the surgery is pretty painless. Now, why is this important? A great example would be, imagine a violinist who has a brain tumor very close to the region of the brain that controls the hands. His living depends on his dexterity. So it's very important for us to know our extent of resection of this tumor. So we stimulate certain aspects of the brain around the tumor to make sure that that is not the part that controls the hand. Through this whole time, the patient is moving his hand as we stimulate. And as soon as we stimulate a part that is responsible for hand movement, he stops moving his hand. He finds it difficult. And that's when we know that that is a part that we cannot reset. In twins conjoined at the head, what's going on? So twins conjoined at the head are known as craniopagus twins. These are really rare. And even amongst conjoined twins, craniopagus twins are the rarest. There are a variety of different ways that the two twins can be joined at the head, and a lot of the treatment depends on how much is joined. Is it only the skin? Is it the skin and the skull? Or is it the skin, the skull, the dura? Or is it the skin, the skull, the dura, and the brain itself? Not only that, we need to figure out how much of the blood supply is going to twin A versus going to twin B, and which heart is supplying which brain the most. So by taking all of these factors into consideration, we try to separate the two twins, try to make both of them live and survive well. Sometimes we aren't able to separate conjoined twins, whether they're at the head or the hip. It's quite surprising that these twins actually go on to do really well. They become best of friends. Whether they like it or not, they're stuck with each other, and they somehow make it work. There are plenty of reports of conjoined twins going on to getting married to different people, having kids as well. So all's not lost really, and you've got a best friend for life. What are the neurological effects of listening to music? How do these explain the feeling of getting chills? This happens to me whenever I listen to Utsav by Aruna Sairam and Soumik Datta. What happens is the music gives us a dopamine release, especially in the amygdala, which is responsible for processing of memories. This, in coordination with the limbic system, which is the emotional processing unit of the brain, causes signals to be generated to the autonomic nervous system, which causes you to get goosebumps and get hair stand on end, like I am right now actually. When you're paralyzed from the neck down, are your involuntary organs paralyzed as well? They can be. A lot of the symptoms following paralysis, following cervical cord injuries, depends on the impact, how bad the spinal cord is affected. High cervical injuries from C1 to C5 are usually the ones that are responsible for important organ functions such as cardiac and respiratory function. Apart from cardiac and respiratory function, other things that can be affected are gastrointestinal symptoms and bowel and bladder issues. What are some misconceptions about neurosurgery that you'd like to address? Probably that neurosurgeons are just full of themselves. There are plenty of jokes. What's the difference between God and a neurosurgeon? God doesn't think he's a neurosurgeon. Those don't help. But most neurosurgeons are pretty nice people. It's a big misconception that we're egotistical and we have a God complex. Another misconception is that our job is like Derek Shepherd from Grey's Anatomy, that every day is a beautiful day to save lives. Life in neurosurgery, though it's quite thrilling and quite interesting, it isn't as unpredictable or dramatic, I should say, as Grey's Anatomy. One of the most common side effects of COVID was loss of smell. Is it possible to surgically reobtain the sense of smell once it has been lost? Unfortunately, no. Surgery usually deals with anatomical issues, except functional neurosurgery, which is a different thing. Surgery in general deals with anatomical issues. So if something's broken there, we can fix it there. If something's broken here, we can fix it here. But in COVID loss of smell, there's no nerve that's actually broken. It's just that the nerve has stopped working. So usually it's not possible to regain the smell through surgery. An interesting fact is that the most common nerve injured following traumatic brain injury is actually the olfactory nerve, which is the nerve for smell. How does my brain understand where pain is spatially located? This is one of the most brilliant concepts in neuroscience. This brings us to a concept known as homunculus. There's a sensory homunculus and a motor homunculus. A homunculus is a diagrammatic representation of the parts of the body on the surface of the brain. So a homunculus will be able to show you that our hands, our lips, and our tongue have a high representation on the brain because they're extremely sensitive. And similarly, the rest of the body have different parts of the brain which are represented on it. So when we get hurt at any particular part of our body, a particular part of our brain gets stimulated, which is directly representative of the part of the body that is hurt. And that is how our brain knows where we've gotten hurt. Is there any part of the human body that can operate independent of the brain? No. But if you've ever seen a goat getting slaughtered, you would have seen that once the head has been cut off, it does move its legs spontaneously without the brain's input, obviously. That's because of the spinal cord reflexes that are going on that causes the muscles to contract. So the answer is no, but looking at that is pretty impressive. Can you explain what a neurosurgeon does and how it differs from a neurologist? Though neurosurgeons and neurologists both deal with treating the brain, the spinal cord, as well as peripheral nerves, the approach to these diseases is quite different. While neurologists try to treat these diseases with medicines, neurosurgeons try to operate and cure the patients. How do neurosurgeons open a skull without damaging the brain? So basically what we do is once the patient's under anesthesia, we take an incision over the scalp to expose the skull. After that, we make a couple of small holes over the skull based on where we want to operate. Then we take a really high-speed drill and connect these holes to create what we call a bone flap. And then we just lift the skull off. Then, what protects the brain from the drill and the holes that we made is the outer layer of the brain known as the dura mater, which translates to tough mother because it's as tough as leather, but it's as caring as a mother in protecting the brain. What is a phantom limb? A phantom limb is the vivid imagination of a limb that was previously there, but currently not there. Say a patient has lost a limb in war or because of gangrene or something. The patient is aware that he doesn't have the limb, but yet gets the sensations, usually of pain, of that limb existing. So what happens is that the patient instructs the arm to move, the non-existent arm to move, but the visual feedback that the brain is receiving is that, no, I won't move. And so the brain's like, move, the arm's like, no, yes, no, yes, no. So this kind of solidifies itself in the brain circuitry, and what happens is known as learned paralysis. So Villayan and Ramachandran came up with a brilliant concept of placing a mirror here so that the patient can see his normal hand, and in the mirror, a mirror image of his normal hand, which is actually representative of his non-existent phantom limb. So now, when he tells the patient to move his limb, he moves his normal limb, but the visual feedback through the mirror looks as though the patient is moving his phantom limb. So what happens is that brain circuitry gets reversed and the patient realizes that he may be able to move the non-existent limb. So that is what reduces the pain over time. What is neuronavigation? Moving around with your brain? No. Neuronavigation is basically a high-tech GPS system to operate on the brain. We have a camera in a distance, which acts like a satellite in space. Then we have a small satellite tower, for lack of a better word, fixed to the patient. And then our instruments act like a mobile phone. So by using our instruments in the brain, the camera watches the movement of the instruments in relation to the satellite tower and can tell us the exact location of where we are within the brain. That's exactly how Google Maps works, but this is for the brain. Why is the brain not damaged by the impact from running or jumping? How is it protected from this sort of impact, but not other impacts? Relative to other types of impacts, running and jumping is actually pretty low impact. The brain is covered firstly by the skin and then the skull underneath. After that, we have a really tough leathery covering of the brain known as the dura mater. There are other two thinner coverings of the brain known as the arachnoid matter and the pia matter. But it's the skull and the dura mater that really protects the brain. Along with that, it has something known as CSF, which is cerebrospinal fluid. So you can actually think of your brain as swimming or floating in a pool of fluid. And if you think about it, the impact will be greatly absorbed by the fluid. It acts like a suspension to the brain. However, with other types of impact, such as penetrating injury, such as a bullet or a stab injury, because the force is so high over such a small square area, there's a high chance that it can go through the skull and through the dura mater into the brain. Blunt injury, on the other hand, for example, in vehicular accidents, can cause something known as diffuse axonal injury, which is a global injury to the brain because of difference in the density of brain movements compared to the rest of the skull. How do you find the region of the brain responsible for OCD? Is it the same for everyone? This is a very interesting question. Instead of focusing on OCD, let's talk about brain functions in general. The best way to identify the region of the brain responsible for a particular function is looking for someone who has a damage extremely localized to a particular part of the brain. That person then manifests in certain symptoms, and hence we can come to the conclusion that that part of the brain is responsible for the functions that this person has lost. By this method, we've been able to identify regions of brains responsible for different diseases. So for example, in OCD, a part of the brain known as the anterior cingulate gyrus is usually responsible. Where neurosurgeons come into the picture is when we do something known as DBS, deep brain stimulation. That's when we pass in an electrode under extremely precise neuronavigation systems that put us exactly at that point, and then we can stimulate that area, which then resolves the patient's symptoms. Which is harder, rocket science or brain surgery? This is a question I get asked a lot. Rocket science must be pretty tricky, but it ain't brain surgery. Consider the number of years of training. Add on to that the countless sleepless nights, the daily life and death decisions, and the time spent away from family and friends. It's not even a contest. Brain surgery for the win. What advancements do you hope to see in the field of neurosurgery in the next decade? Neurosurgery is really exciting. It's cutting-edge technology meets hi-fi science. The future of brain tumor treatment is pretty exciting, with efforts being made to kind of penetrate the blood-brain barrier. But for me personally, the most exciting thing is brain-computer interfacing. Imagine being able to read someone's thoughts, though this is decades away, but at least the fact that we can even move arms and control computer screens just through our minds is truly sci-fi, and I'm in for the ride. I had a lot of fun talking about my favorite thing in the world, the brain. See you next time. Thanks a lot, Answered.